Dr. Pradip Mohanta is the director of Netra Jyoti Eye Hospitals, West Bengal, and is a teacher par excellence. He has contributed majorly through his video library, and today he'll be enlightening us. Over to you, Dr. Pradip.
He was here. Dr. Pradip?
He's there.
He's muted.
No, he can hear us. No, he has to share his screen.
Share his screen.
Dr. Pradip, can you share your screen?
No, it is with you.
No, you have to show the video. I kept writing in the group.
Should I share that?
Okay.
Yeah, yes, Mr. Sunil, you share his video. It's a wonderful video. You could share. In the interim, yes.
This is a very hard cataract. The purpose of this video is to show that I get clear cornea next day if I employ submarine chop in such rock hard cataracts. After a large rhexis and gentle hydrodissection, the antechamber is filled up with hydroxypropyl methyl cellulose, and then the tip of the phaco needle goes in with its bevel down, some superficial cortical lens matter is removed, and then the handpiece is turned to make the bevel up. Now, with the help of this chopper, the nucleus is pushed a little down and the tip is buried into the substance of the nucleus just in front of the main incision. It goes through the substance quite some distance and goes near the opposite equator, and the nucleus is chopped. A very good crack is obtained. 180-degree rotation and few scalps, and along the initial crack, the nucleus is divided completely into two heminuclei. And this is the larger heminucleus. I'm going to divide this into three pieces. This is one, and this larger piece is again divided, so we get three separate pieces from the larger heminucleus. Come to the other heminucleus, and it is divided into two pieces, so we have got 5 pieces. And now we're going to emulsify these nuclear pieces. Phaco power used is 80% in continuous mode. Flow rate is 45 ml per minute. Vacuum is 450 mm of mercury. Emulsification of the triangular pieces is carried out starting from its apex. Look here, the piece is tilted and emulsification is started from the apex. Emulsification of the pieces are carried out in the anterior part of the capsular bag, just below the iris plane. One more thing you can note, that no small pieces are running here and there, and it is not hitting the posterior corneal surface, not hitting the back of the cornea. I come after emulsifying half of the nucleus, refill the antechamber with 2% SPMC, and again go in and emulsify the last 2 pieces. When I use SPMC, hydroxypropyl methyl cellulose, this is the strategy in hard cataracts. Come out after emulsifying half, refill the SE with SPMC, and again complete the case. This is the last portion of the last piece. At this time I come to phaco on mode, where the vacuum is only 80 mm of mercury, and thus the nucleus management is completed, cortical cleanup is done, and an intraocular lens is implanted. Now see the post-op pictures just after 18 hours. crystal clear cornea, anti-chamber quiet, unaided vision is 6/12. Thank you very much.
Thank you, Dr. Pradip. That was a very daring surgery. Very good. There was a new tip. But I do feel that your X's were nearly 6 millimeters in these eyes to go ahead and do your submarine chop. I think for premium IOLs, when you are very particular about having a smaller X's, what is the opinion of the expert panel? And one thing I want to ask Dr. Pradip, could you tell us the parameters which you have used through the course of the surgery?
Yes, can you hear my voice?
Yes.
Yes.
Yes, sir.
Yeah. The phaco power was 80%, flow rate was 45, and vacuum was 450 millimeter of mercury. The machine is Oakley CATARACT 3.
You also mentioned about continuous mode.
Yes.
Continuous.
That your routine for these hard cataracts?
Yes.
Also
Yes.
do the burst mode.
No, continuous.
Can I ask?
I think
Mitra?
that is, may I comment on that?
Yes. Yes.
Beautifully
Mitra, can I comment?
I mean, it worked very well in your expert hands. But I think the reason Anaga asked was, I mean, this doesn't have the ellipse or the nozzle. Obviously, it's also an excellent machine. But most often, I would have gone for a interrupted power in this case, pulse power, because even though it was a very hard cataract, even in these situations, it would do well. And even though you kept emphasizing HPMC, I also generally use HPMC. But this is one of the situations where I would like to use a combination of hyaluronic acid and chondroitin sulfate, something like the Viscoat. Now, very good Indian alternatives at a cheaper price is also available. The other thing is, though you chopped it beautifully, I think in these hard cataracts, I would, in the subincisional area, I would create a small trench. And that gives me a good approach to the meat of the nucleus and helps me to create the first chop in a more controlled manner. Otherwise, what you did seemed to work very well. But I would slightly differ on the settings, because even in these hard cataracts now with the modern machines, I think 80% continuous is not needed, and you could get away with a slightly more gentler settings.
Mitra, can I add?
Yes, Dr. Mohan.
Pradeep, nice presentation. In fact, we had this discussion. Ramurthy also knows about it in the Shankar Netrala alumni webinar. The same case, submarine chop you showed. You had a good Rexus, fairly good Rexus. I use about 5.5, which gives us the space, especially because these are all very big cataracts. But these are about brown, black cataracts, what you showed just now. And I would suggest that using the continuous phaco power 80%, 100%, and bringing the nucleus slightly up and using only HPMC, I can't guarantee clear corneas like you. I'm very, in my opinion, I cannot. I use Viscoat for all these cases. I use hyperpulse or the cold phaco because that minimizes the phaco energy. Whatever you say that the last time you were mentioning about the phaco energy getting delivered into the nucleus. Please understand, if it's getting delivered only into the nucleus, ultimately the energy, the heat has to come to the endothelium as well. So I can't understand how the corneas can be clear with the continuous phaco energy you're using, so much of phaco energy you're using, and also you're not using any Viscoat or any dispersive viscoelastic for that matter.
Plus,
So,
more chance of a wound burn also. Surprisingly, there was no wound burn in your case.
He is a great person, but
he's a fantastic surgeon. No, full marks, Pradeep.
Absolutely.
No, that's what I'm trying. I want to learn from him how he is able to deliver clear corneas, because I do these cataracts regularly. I use my sharp chopper. I do the vertical chop. I don't do the horizontal chop or the submarine chop like you, but I use the vertical chop, and I use Viscoat now and then into the anterior chamber repeatedly. About 3 or 4 times I use Viscoat, and despite the fact that I'm able to deliver, crack these cataract or chop these cataract to multiple pieces as well. And I use always the hyperpulse or the micropulse or the nozzle or the ellipse or whatever cold phaco technology which is available with me.
I think one other observation.
I also don't use Viscoat. I always use HPMC, and mind it, the corneas are clear. So I really don't see that it is obligatory and mandatory to use Viscoat for that matter. Continuous is something, yes, something which, but deeper plane emulsification, dividing into smaller pieces, keeping the nuclear pieces away by using a chopper shield at times, using viscodispersive coating like with the HPMC will also suffice in these patients. So these are the few things, but I really don't agree that you have to use viscoat is obligatory and mandatory. Even if you're doing deeper planes, smaller pieces, chopper shield for that matter, I think that should suffice by all means.
Maybe as a message to be sent across to the general routine cataract surgeon. For a panel like you all, definitely it may not be required, but if you have to send a message across, then maybe it would be prudent to use it.
Rohit, there is enough and more evidence to show that the endothelial has receptors to bind to chondroitin sulfate. It does not happen with to that extent with sodium hyaluronate and does not happen with HPMC. So these binding of the chondroitin sulfate to the receptors of the endothelium gives the additional protection, and it does not wash away to that extent or that easily because of this binding. So that is first thing. Chondroitin sulfate, I think without dispute. When you go on to BSS plus, that also without dispute. Cold BSS plus, that would be. So these are a couple of things that you need to actually look at. You are absolutely right, Mohan. Just a point which Rohit also made. If you are actually using a lot of energy deep into the nucleus, it does not dissipate to that extent. It is the interior levitation that you do which causes the problem. And one observation that I just wish to ask from Dr. Pradip is that normally whenever you are doing a hard cataract, in his case also, he was using a large bore phaco needle. So that I never go on to the thinner and the bent and whatever the needles which are provided by some companies which have a thinner lumen in between, because they get invariably stuck. If I am using an infinity with such a hard cataract, I have to really flush it because it really gets stuck again and again. But if you go on to a signature machine and you are using the larger bore of the needle, then these get sucked up very easily. And that is the other thing, that don't go to, but you have to be a good surgeon like Dr. Pradip, because the fluidics will be high. And if you are using a large bore needle, that the surge control mechanism should be good. So whenever we are on a large board, on a very rock hard cataract, a large bore needle would be there, and being away from the endothelium is the key. And whenever you do a large capsulorhexis, one of the things that happens is that you tend to come reflexly a little forward, because the whole thing is tending to come forward. And that is Rohit's technique of keeping a chopper in between to keep the whole thing behind is very, very important. But Rohit, chondroitin sulfate Indian is pretty cheap, and the quantum is pretty low, 2 ml. So you can actually use them in a couple of cases.
Just to add one more point, Chitra, just adding one small point.
Gets washed away as soon as you put the phaco probe inside.
Viscoat doesn't get.
No, viscoat you have to aspirate. It takes time to aspirate viscoat. So,
viscoat is a must for all these hard cataracts.
So one small point I wanted to make was that there are sometimes small fragments which remain at the wound site, at the main wound, and in the iris crypts, which, in the hard cataracts, we often, escape our attention, especially when we finish the case. So always it is best to, when you're putting the instruments, always best to check this at these sites, the side port and the main wound and the iris crypts, that there are no small fragments which are, hidden and remaining there.
Very important point.
Very much. We go